there's 3 short dog heart videos. They do a dog and do CPR on the dog. So that'll be fun. And then there's a hamster cheek pouch. You pull the cheek pouch out and they do the vascular. So a lot of the videos are on the cardiovascular system. So you'll say, wow, there's so many, and then all of a sudden there won't be any left after that. There's quite a few. So when we look at this, today we're going to be looking at a lot of the electrical activity of the heart. We'll start off by looking at the cardiac muscle a little bit, and then we'll shift our focus. This is illustrating a cardiac muscle cell. You probably remember that we have 3 types of muscle cells. We have skeletal muscle. Skeletal muscle is voluntarily controlled and striated, meaning it's banded. And we have smooth muscle, which is involuntary and non-striated, non-banded. And then we have cardiac muscle. Cardiac muscle is striated and involuntary. And so cardiac muscle is really designed for its role in contraction in the heart. And so it has some additional features that the other types of muscle don't have, and these are the intercalated disc. The intercalated disc not only help hold the cell muscles together so that when they're contracting they don't pull apart, but they also form some gap junctions so that ions can move through, so the wave of depolarization can spread quickly from muscle cell to muscle cell through the atria and through the ventricles. And so that's another thing that's helpful. Of course, they have lots of ATP in them as well. Well, when we look at the heart, we can say that there's 3 main principles or categories of what the heart is doing. We need the mechanical, that's the contraction. And we need the electrical, and we need the vascular, the blood supply. These are all interdependent on each other, and if we have problems in any one of these, we can have problems in the other. Okay, so those are sort of the 3 that we have. So when we're talking mechanical, what we're really referring to is the contraction of the myocardium, the muscle in the heart. And of course, what it does is it moves blood through the heart. So it contracts, moves blood through, and then it relaxes. And we have that alternating. The mechanical aspect must be coordinated by the electrical. The electrical initiates the contraction. It tells the heart muscle when to contract and all of that. So the electrical is very important, and we're going to focus a lot on that at the beginning here today. And then we have the vascular. The vascular is the blood supply, and we have to bring a lot of oxygen and nutrients to the cells. Of course, we have to take metabolites and carbon dioxide away, but the vascular, the blood vessel supply is vital. If we have a decrease in our blood supply, we'll mess up our electrical and eventually our mechanical. And so they definitely need to work together. Now when we look at the heart, looking at the electrical aspect, we know that the heart is autorhythmic. What that means is the cells of the heart have the ability to reach threshold automatically, like on a timed response. And the main pacemaker of the heart that paces the entire heart is the sinoatrial node, the SA node. Way up in the right atrium, we have the sinoatrial node or pacemaker. All the muscle cells of the heart can also act as pacemaker, but they have a more positive threshold. So the real pacemaker, if it's working correctly, will be our sinoatrial node. That's the one that's going to do it. When you start the pacing of the heart, you then have to send that wave of depolarization throughout the heart. First through the atria, then you go to the AV node, the second pacemaker, then it shoots down to the ventricles, and you get your depolarization followed by repolarization. That is automatic. That pacing of the heart is automatic. It gives us our resting heart rate, if you will. If your resting heart rate is 70 beats per minute, it is the sinoatrial node that's generating that rhythm. Now, even though we have an autorhythmic functionality of the heart, pacing of the heart, we can increase and decrease the heart rate around that normal rhythm. That pacing comes from the medulla oblongata, the cardiac center of the medulla oblongata. And if you want to increase the heart rate, you'll send sympathetic neuronal input to the heart with norepinephrine, or endocrine with epinephrine, and you'll increase the speed of the heart, the rate of the heart. If you want to slow it back down, then you use acetylcholine. You use the vagus. You use the parasympathetic, mainly the vagus. Cranial nerve 10, you may remember, and that, using acetylcholine and muscarinic receptors, will slow the heart rate. So if you're exercising, your sympathetic system raises your heart rate while you're exercising, and then when you're done exercising, the parasympathetic lowers it back. So you have your basic pacemaker rhythm, which is intrinsic, but then you have the extrinsic control, sympathetic and parasympathetic, which can raise it and lower it around that standard. Okay, so far? All right. Well, so we want to understand how this sinoatrial node, and if you're in a hospital or something and they say normal sinus rhythm, that's what they're talking about, the sinoatrial node. It's normal sinus rhythm. How is it going to be autorhythmic? How is it going to spontaneously reach threshold? First of all, our resting membrane potential in these little clump of cells that we call the sinoatrial node, their resting membrane potential is about -60 millivolts. Not -70, which we see primarily in the neuronal system. Not -80, which we see in the ventricular muscle system, but about -60. And what they're able to do is they're able to spontaneously have a depolarization from -60 to -40, which is threshold, which will then open gates, which will cause an action potential, which will then spread from the sinoatrial through the atrial cells, to the AV node, eventually to the ventricles, and that way. So it spreads in that way. So the resting membrane is not stable. It drifts up.
Just
Automatically. Now why? What's the mechanism? We're going to talk about what the mechanism is for that drifting. Before that, let's look briefly at the conduction system.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
Okay. This shows a little diagram of it. Here's the sinoatrial node. This is where you're going to initiate it. That's spontaneous depolarization, spontaneous reaching of threshold. Then they'll go through the atrial myocardial cells very quickly. And of course they're spreading through these gap junctions, the intercalated disc. Then they reach the AV node, atrioventricular. They pause just for a little bit there, and then they shoot down this conducting system. This is called the bundle branches. The old name was bundle of His. It's still listed here on the diagram. We don't use that name too often anymore, but these bundle branches, they come down. And then they spread around these little Purkinje fibers. These are conducting cells within the heart. Probably about 1% of the cells in the heart are conducting cells. And they'll help shoot the signal down and around very quickly, because the ventricles are much bigger than the atria. Then they go from myocardial cell in the ventricles, and they'll spread through the whole ventricles. Now, we want the atria to depolarize first, and then the ventricles, because we want the atria to contract first. The electrical event causes the mechanical event of contraction, because the filling, passively you fill up about 70% of your ventricles with blood, and then the atria contract and it fills it up the rest of the way. So you want your atria to contract first and then the ventricles. It needs to be correctly sequenced. If it's out of sequence, we've got problems. And so we need that to happen. And this shows you the bundle branches. It shows you all that moving around as it's coming around. Now, it depolarizes and then it repolarizes. Okay, now here we have the action potential in the pacemaker cells. Okay, so the action potential of the pacemaker cell. We go from about -60 up to about -40. We reach threshold, we get a depolarization, then we get a repolarization, and that's it. But going from the -60 to the -40 is automatic. It's like on a timer by opening channels. Now, what channels do we open? Well, we open some in sequence, and this shows it how we're going to open them in sequence. So the first one is, these are our channels. Where are they at? The sinoatrial nodal cells in the membrane, right? That's where they're located. We have some funny sodium gates.
Is that the ectomeninal?
It is, but they're not comedians. They're called funny because they're unusual. Funny, but that's why they have a little f. They're funny because they're atypical, all right? They're atypical because they can open on their own and close, of course, shortly after. So we have those. Then we have some transitory calcium gates, and then we have some long-term calcium gates, and then we have some potassium gates. These are gated channels, all right? So what happens is, first of all, your unusual, funny sodium gates open. Sodium starts to come in and gets you partway to threshold, partway to -40. Not all the way. But as these are just closing, the transitory calcium gates open. Imagine that picture is actually showing them to be open, should be open there. And the calcium comes in down its concentration gradient, and it takes it the rest of the way to -40. You have now reached threshold. What happens at threshold? It's a little bit different. We open long-term calcium gates, not sodium. And why are they called long-term? Because they're open longer than the transitory, okay? So they open, calcium comes rushing in to a greater degree and causes that depolarization. This right here. Then those close, our potassium gates open, and we repolarize. This is our sinoatrial nodal action potential. And it is autorhythmic because these gates, the unusual sodium and the transitory calcium gates, open automatically. So they're kind of revolving. They open, they let it in, they close, and they open, they let it in, they close. So they're changing their position, their conformation, and going from the open to the close to the open. And it's only milliseconds we're talking about.
Some people have like heart arrhythmias. Is that due to something wrong with this, or is it later on that it bumps this?
Could be one or the other, right? It could be your pacemaker or it could be your conducting system. Now we know sometimes you have to put in an artificial pacemaker. Okay, something's going wrong with your pacemaker. A lot of times, not always, it's a lack of blood flow. Okay, then it's not working right because you're not getting the energy to move the ions around and do all that kind of stuff. But it can also be with your conducting system. Sometimes there's a short circuit, sometimes there's a little tissue that's hyperactive and you have to go in and ablate it, do something like that. So it could be your pacemaker cells or it could be your conducting system.
It's very complex.
Complex. And it could be due to a lack of oxygenation, blood flow, or it could be that some of the cells, for sometimes complicated reasons, become hyperexcitable, or they're having a short circuit where it jumps from here to here and it skips some things, and so you're getting arrhythmias due to that. So any of those things could be a potential problem. But this is the normal, this is the way it's supposed to work, right? Now, that's our normal rhythm. Let's say 70 beats per minute. This is going to open 70 times per minute. This process is going to go through that. If we want to speed it up, we have beta adrenergic receptors. Norepinephrine and epinephrine can bind to these and they can speed things up. They can also increase the contractility. The parasympathetic to muscarinic, acetylcholine to muscarinic cholinergic receptor, can slow it down. So we can speed up both the heart rate by affecting the pacemaker, the sinoatrial node, and we can also affect the contractility, and we can also slow it down. So this system is controlled by the cardiac center in the medulla oblongata, here in the brain. And it controls it via the nervous and endocrine system.
Just from this little graph, is this showing that ventricles have a separate receptor for
No, it's really the same.
Okay, I was confused. It's like
Yeah, it's a little, it's oversimplified because it's not really showing it to the sinoatrial node, which they go both norepinephrine and acetylcholine. But what it's trying to indicate is you have receptors both in the atrial myocardium and ventricular myocardium. You actually bind to the same receptors for both norepinephrine and epinephrine and the difference. So it's a little oversimplified. Yeah, that's true. Notice the sympathetic is your thoracic spinal nerves, thoracolumbar, right? That's the sympathetic. So that's coming from. So we can increase sympathetic and increase heart rate, and we can decrease parasympathetic, that will increase Now, this is an important one because it shows us, it illustrates a little bit more the mechanism of how the sympathetic and parasympathetic work at the molecular level. A is our control. That's our normal. From A, if we're gonna go from -60 to -40, we're gonna open funny sodium gates, then we're gonna open transitory calcium gates, and that's gonna get us from here to here. Then we're gonna open long-term calcium gates, and that's gonna get us from here to here. Then we're gonna open potassium gates, and that's gonna get us back here. That's our normal. Okay. We can manipulate that system. B shows sympathetic. What happens with sympathetic? We open the gates faster, the sodium and calcium gates. And notice the slope of the line. It's steeper. Instead of taking this long from here to here, it takes shorter, right? That's going to increase our heart rate. What about C? That's going to be parasympathetic. That's going to slow it. Look at, it's going to be a longer, more gradual slope. It's going to take longer to get to threshold. So B is increasing sodium and calcium influx due to norepinephrine and epinephrine binding to beta-adrenergic receptors. It changes, they open faster, those gates. C, the mechanism's a little different. In this case, you open more potassium gates. Potassium is repolarizing, but it also, if you have the potassium gates open, potassium positive charges is going out. Let's make it at the instant more negative, right? It takes you longer. It's slowing the rate to get to threshold if you're opening those during your action potential, during your normal action potential. So the slope of the line is extended, and that slows it down. And that's how we can change it. We can manipulate our normal system. Now that's the sinoatrial action potential and the molecular mechanisms, the gates that underlie it. You can see, by the way, if you screw up your concentrations of ions, potassium or something like that, that can screw up your heart rate. If you have cardiac patients, a lot of times you're checking their potassium levels about every hour or so. Because if you get them off a bit, you can throw them into arrhythmias, okay? So there's things like that that we'll just sort of mention briefly to show you that things can affect our normal mechanism. Well, now, this is a different action potential. We're not talking about the sinoatrial pacemaker cells now. We're talking about the myocardial cells, especially the ventricular myocardial, because they're bigger and there's more of them. They'd be similar for the atriomyocardial, but the ventricle. This is a typical ventricular myocardial cell action potential. Looks very different from the sinoatrial node, doesn't it? Now here, we have a much more negative resting membrane potential. It's probably about -80. And we reach threshold by the wave of depolarization that gets to that myocardial cell. That started from the sinoatrial node. That's what triggers the change from resting membrane potential to threshold. When you get threshold, you're opening voltage regulated sodium gates again, not calcium. You increase the permeability to sodium, sodium comes in, you get your depolarization. Then you start opening, you close your sodium gates, you start opening potassium, you start repolarization, but then you open some long-term calcium gates. See the calcium going up, permeability, potassium going down. And calcium starts to come in, and you get a little bit of a standoff between potassium going out and calcium coming in. It's still going down a little bit, more negative, a little bit of repolarization, but it's not going straight down. It's got this plateau phase. That's what we call it, a plateau phase. This lengthens our action potential. And then the calcium gates close about here, the permeability going down, and potassium gates open some more, and you get your repolarization. It lengthens the time it takes for a myocardial cell to contract. Why do we need that? Okay, here's why we need that. First of all, in skeletal muscle, it's perfectly fine to have lots of contractions that summate, they add together. Stronger and sustained contraction. You can hold something, can't find anything heavy, but you can hold something for a long time because your skeletal muscles are getting a constant neuronal input and they're in a fused contraction. We call it tetanus, okay? Perfectly fine in skeletal muscle. That would be disastrous in cardiac muscle. What we need in cardiac muscle, we need it to contract, push the blood out, and then we need it to relax, fill the blood back into the ventricular chamber, then contract again, then relax. We don't want it to get to a sustained contraction. Basically, you're losing a lot of efficiency if you have a sustained contraction. It doesn't work. So this lengthened action potential means that those cells are in absolute refractory period for a longer period of time, so they won't respond to another signal until they have the muscle relax. Then they can respond again. So that prevents muscle sustained fusion contraction. And that's what that's looking at. So that's that action potential. Now, a few of you did some ECGs in lab. The rest of you do it on Thursday. The old name, which is still used sometimes, EKG, it comes from the German. Cardio is K, starts in German. So it's perfectly fine to call it EKG, but we usually say ECG here because it makes more sense in English, electrocardiogram, and that's what it is. The nice thing is we can monitor the electrical activity of the heart from the surface, non-invasively. We can slap the electrodes on and they can look at these summations of the electrical depolarizations and repolarizations as they move across the heart. And we can track that. Then we can say, okay, this is normal and this is abnormal. And so that's very helpful diagnostically. So we look at electrocardiograms. Now remember, this is looking at electrical activity. It's not measuring blood flow at all. Now, if you have bad blood flow, it'll affect your electrical activity, but that's not what it's measuring. It's measuring the electrical activity. And this is a typical electrocardiogram. They often don't look quite this nice when you're doing the tracing, but hopefully it'll look pretty similar to this. Now, in so many ways, when we label something or name something, we give it a complicated name or a name that doesn't make sense or anything. Whoever did us all a favor. They started with P for we don't know why, but then they just went alphabetically. Thank you, P, Q, R, S, T. Oh, yay. So that's nice. They just made it a little bit simple for us. So the first deflection or wave is the P wave. Then we have a little downward wave, which is Q, then a major upward deflection, which is R, then a downward S, and then an upward T. So those are our waves. Now each one of these waves are measuring some electrical activity in the heart. The P wave measures depolarization of the atrium. That depolarizes first, right? It comes from the sinoatrial node, goes to the atria first. That's the P wave, atrial depolarization. The QRS complex of waves measures two things. One, ventricular depolarization, and two, atrial repolarization is lost within that QRS complex of waves. It's within there, so it's part of it. And then we have the T wave. The PR interval is the time when the atria start to depolarize until the ventricle is starting to depolarize. We'll see if that's lengthened. If you watched the turtle heart, you already saw, and you talked about that somewhat. That's if that is lengthened, it's longer than it should be, that's a primary heart block. If that's lengthened, that's a definition of it. Now, we're supposed to have one P wave to one R wave ratio. The atria depolarizes and contracts, the ventricles depolarize and contract. If you have the atria contracting or depolarizing twice or three times before your R wave has a chance, your conduction is so slow that you have 2 or 3 P waves before you get to R wave, that's a second degree block. If it's totally independent of each other, that's a third degree block. So what does the T wave represent? That's ventricular repolarization. Here's the P wave with the atrial depolarization. And then as that's repolarizing, the ventricle's depolarizing, that's your QRS complex, depolarization of the ventricles. And then we have repolarization of the ventricles, shown in red there. So we can trace all of that. So every ECG tracing is essentially one heart event, electrical event. This is just showing you that because the ventricular action potential is in its absolute refractory period longer because of that plateau phase, you're not going to respond to another input until you get down to the repolarization of it again. So what kind of arrhythmias do we have? Well, tachycardia is a resting heart rate, not an exercise, a resting heart rate over 100 beats per minute. Generally we say between 100 and 200 beats per minute. We call that tachycardia, that fast of a heart rate at rest. Bradycardia is generally a resting heart rate of less than 60 beats per minute. Flutter is a resting heart rate of between 2 and 300, over 200 beats per minute.
That's not bad.
That's really fast. And fibrillation is your heart is not beating as a unit anymore. Individual cells are popping off, but it's not beating as a unit anymore. And that's fibrillation. We can have atrial fibrillation, and we can have ventricular fibrillation. This shows some of this is the normal. Notice here we have 2 P waves to every R wave. That's second degree block. And then we have third degree block where they're just independent of each other. This shows it another way. First degree block, your PR interval is lengthened. Second degree block, you're getting 2 or 3 P waves per R wave. Third degree block, the atria and the ventricles are beating independently of each other. They're not sequenced anymore at all. This is tachycardia. Remember, every time you count the R waves, that's, if you know it, their time frame that you're talking about, you can calculate your heart rate just by calculating the R waves. Easiest to count the R waves, count the P waves or anything else. But, so tachycardia less than 60 beats per minute at rest. That's bradycardia. I forget if I said it right or not. Anyway, that's bradycardia. Tachycardia is over 100, usually 100 to 200. Flutter, over 200. And then fibrillation, you see there's no discernible pattern. P, QRS, T waves in ventricular fibrillation. This tells us about the different reasons why. Now, let's talk about fibrillation a little bit here. We need our muscle cells to contract together in sequence. One cell contracting here and then here and here, it's not going to move blood, you know. We need them to contract as a unit. And the atrial muscle contracts first because it's depolarized first, and then the ventricular muscle. So you push blood from the atria down to the ventricles, then ventricles contract and you push it out. Okay. If you lose that sequence, so that just individual cells are contracting on their own, not synchronized together, you're in fibrillation. Atrial fibrillation is one of the more common cardiac disorders that we see. We call it AFib for short, right? So if you have AFib, your atria are not contracting as a unit. Now what that means is you're still getting perhaps 70% of the ventricle filling with blood passively, but then the atria is not contracting as a unit to fill it up to the other 30%. So you can live with AFib, but it gives you a higher risk for strokes and myocardial infarctions and other things. And you're not getting as efficient a movement of blood through the heart, not as efficient with cardiac output. So they often will try to fix it, but sometimes you can't fix it. They'll often give you a blood thinner to try to make it so that the workload of the heart is lessened and it decreases your stroke risk and things like that. So some people, they live with AFib for years, and there isn't necessarily a resolution, but they're treating to try to prevent strokes. Ventricular fibrillation, VFib, you cannot live with VFib for very long at all. I'm talking minutes here, right? VFib is when the ventricular muscle is not contracting as a unit. It's just individual cells are popping on. And you have got to get it synchronized. And that's where you're going to use the paddles or what have you and say clear, and you're going to shock. You're trying to resequence it all so it'll start the normal sinus rhythm on its own. You could do that with internal paddles if you're doing surgery, or they could be external. And what do we call it? A defibrillator. We're trying to get the patient out of fibrillation, right? So you're using a defibrillator to shock the heart to try to resequence it so it'll start. It's absolutely necessary to get the heart started going again, sequenced, or else you can't survive VFib for very long. A lot of patients in VFib, even if you shock them, the percentage that you get back is pretty low. So we have around campus a lot of these vests with the automatic defibrillators. There's one in Clark Hall, there's one in the gym, there's one by the pool. I don't know where else. So
It's probably one or something.
probably, I mean, in the nursing department, we think we have it.
Give them live practice.
Get the practice. After the test, you know, everybody goes into VFib.
Low score.
Shock them out. Shock them. Yeah. These, the kind they make now, they put a vest and you put it in and it automatically does it. Now, what's CPR? Cardiopulmonary resuscitation. If a patient's heart is not beating, if they're in VFib or something like that, while you're trying to get their heart going again, you're doing compressions on the heart to try to push the blood mechanically out of the heart. It's not beating on its own, to get blood and oxygen to your brain and to your kidneys into your heart to keep the person alive. And you don't always do the respiratory part, but you can. You can do the breathing, and that's to try to get, air coming in. And so if a person is drowning or had an electrical shock or whatever else, and their heart's not going, you can give them, for a while, CPR, and hope their heart starts on its own, or you give them the defibrillation if it's in VFib, and you can try to get it started and get it going on that. So that's the idea. So it's a temporary measure, the CPR, to try to keep them alive until you get the heart going. So that's what that's talking about. Any questions or comments about any of this that we're chatting about?
What makes someone more, I guess, is there any predisposition to have someone have AFib? Or is it genetic?
Some people have congenital, born with electrical issues with their heart. And then, of course, most of the time, well, VFib can become for a lot of reasons. A lot of the reasons that you're going to get VFib is a lack of oxygen to the muscles, so you can't make enough energy. A lot of times you get that because you get an occlusion, a blockage in the coronary arteries. So that's a myocardial infarction. That infarction means some of the tissue's dying, that's a heart attack. Well, you can go into VFib just with a lower blood flow, ischemia. So if you have ischemia, then all of a sudden they go into VFib, and then they have a myocardial infarction. That's probably the most common. You can also get congestive heart failure. Your heart is getting weaker and weaker as you're getting older, and so it's not pumping out as much as it can, so it's not getting enough oxygen to itself, and eventually you can go into VFib. A lot of patients, they go into AFib first, and they might have AFib for a year, but then it becomes very serious if they go into VFib. So, in most cases, it's not a genetic predisposition. It's age and lifestyle and blood flow. If your coronaries are getting constricted because of arterial sclerosis or plaque and whatever, that, of course, can decrease your blood flow. That will affect your conduction system, and it can throw you into AFib and VFib eventually. So yeah, that's generally what's happening. But there are cases where, yes, there is a predisposition, but that's not particularly usual.
Why are we able to give compressions, but we don't necessarily need to give breaths?
They used to always tie them together, and then they decided that in a lot of cases, the breathing part wasn't as necessary. Depends if the patient's breathing or not. If they're breathing on their own, then you may not need to do the respiration. Usually if the patient's been drowning, they have water in their lungs, and you're trying to get them, and then you give them the air. That's probably more common when you pretty much want to do it. But if they just go into heart failure and they're still breathing, but their heart stopped, cardiac arrest, then you might just do the compressions without doing the breathing. So it's sort of be dependent on the circumstances that you see. It's not that it's bad to do mouth to mouth, and of course they have, if you're in the emergency, they have the devices you put in, you breathe through that, but in some cases it's not necessary or as necessary. And one of the challenges of CPR is, even if you learn how to do it, you can forget. Sometimes you can kind of screw it up, and so that can be a challenge. In older patients, and they'll often have interns or code blue and the patient's crashing, they'll have them practice CPR. But if the patient is, 90 years old or something, you're doing CPR, and you're all hyped up, in most cases, you're gonna break their ribs. Because they're older, so their ribs are weaker, sternum ribs, and then you're too hyped up, so you're, and then you're gonna hear the ribs crack. So, there's side effects, there's risk factors, so obviously, you generally do that with somebody who's still a code, but older where, they probably aren't gonna recover anyway, but, not to say they won't, but that's the case, you're trying to save them, but there's other risk factors like breaking the ribs, cracking the ribs.
And then I have another question, could you still put like a defibrillator on if they have a pacemaker, or like, will that affect anything?
Well, that's a good question.
You're not supposed to put it directly over the pacemaker.
So you just move it aside. Okay, thanks, because I wasn't sure. I think, because a lot of people have pacemakers that, and I think they could, but so you put it in a different spot.
Yeah. Like, that's one of the things that they'll do. Do not put it directly over a pacemaker. Do not.
Pacemakers are, a lot of times, they're under the clavicle.
Yeah.
That's a
If you
cutaneous.
notice the bulge there, so it's not.
Yeah, so I put it there. That's good to know that, cause I, yeah. So that's helpful, isn't it? Good stuff, wow. So next time, we're gonna go over the mechanical. We're gonna go over the cardiac cycle.